Hello and welcome to the 12th Annual Advanced Practice Nursing Conference, hosted by the Graduate Nursing Students Association from the University of Manitoba's College of Nursing. Thank you everybody for joining us this evening. My name is Hannah. I'm one of the co-chairs along with Ashley and our secretary Suzanne. We are all part of the APN Conference Committee Executive Team. Before we get started, I'd like to acknowledge that the University of Manitoba campuses are originally located on the lands of the Anishinaabe, Cree, OG Cree, Dakota, and Dene peoples, and on the homeland of the Métis Nation. We respect the treaties that were made on these territories, we acknowledge the harms and mistakes of the past, and we continue to dedicate ourselves to move on in a partnership with Indigenous communities in spirit of reconciliation and collaboration. The topic for this year's conference is the role of the APN in trauma-informed practice. We have 4 fantastic speakers who are lined up to speak on this topic as it applies to their practice and their experience as APNs. Our speakers tonight, in order of presentation, are Dr. Nicole Harder, Jessy Dame, Rhonda Campbell, and Jennifer Cumpsty. Following each speaker, we will have a 5-minute Q&A session, so please feel free to put your questions into the chat or raise your hand. Our committee members, Jess and Karen, will be reading the chat.
So we acknowledge that certain topics that may be discussed in our conference could be potentially distressing for some attendees. Recognizing this, we have Natalia Mosel present this evening, who is a Canadian certified counselor with the University of Manitoba's Student Counseling Centre. If you need support, please reach out to her. We will include her email address in the chat box, or you can message her directly through the chat feature as well. This conference is also collaborating with One Just City, and we are collecting donations in support of their West Broadway Drop-In Center. The GNSA will be matching the donations made on behalf of this event. And our final note of the evening is about our door prizes. Everyone in attendance who is registered on Eventbrite will be entered into a draw to win one of 3 grand prize gift baskets, including a wellness package with a Thermia gift certificate, an entertainment package with movie passes and games, and a movement package with a gift card to Wheelhouse Cycle Club. There are also 5 e-gift cards available. Winners will be notified by email. The email they use to register on Eventbrite and will be posted on the GNSA's social media accounts. Without further ado, we would like to welcome Knowledge Keeper Leslie Spillett to bring her opening remarks.
So good evening. It's just always such an honor to sit with you all during these gatherings. I do also want to acknowledge the work that Ashley and Hannah and Suzanne have done to bring us to this evening, and also Miigwech for that gift that you brought over to my home the other day. I think it was Saturday, but I'm not sure. So Tansi Nitodamek, I wanted to start by establishing our connections to each other, that we are all related to one another. And when I think about trauma-informed practice, I think at the core of that is that value, is that understanding, is how interconnected that we are as human beings, and also everything else in the natural world we're so dependent and interdependent on. Also want to acknowledge this evening Dr. Dick and my other colleagues from the College of Nursing and Makwa Omashkikim, the PINE, Pathways to Indigenous Nursing. And I always feel really honored to have an opportunity to work with the Indigenous students at the College of Nursing. So my name is Geji Goweabikwe. My clan is the Bear, and I originally from northern Manitoba, and I grew up in a very small community called Wekusko. It's close, it's between the Paw and Thompson on the Hudson Bay line. And we, you know, my journey in life was very much connected to Canada's colonial history and our displacement. But I always honor that territory because that's where my ancestors are. And when we say our names to the universe, to the cosmos, our spiritual names, it's a way of calling back to them, calling back to those ancestors 7 generations previous, to sit with me, to sit with us tonight as we start this this very important work. I have to say that I've been a part of the missing and murdered Indigenous women and girls and Two-Spirit community for many, many years, and including participating in the national inquiry in just a very small way, and understanding in a very deep way how important trauma informed practice is. It is, I think it's underpins all relationships, but none so much as when people are at their most vulnerable when they come into healthcare settings, and how important it is to acknowledge our humanity in one another. So that's why I say that relationship is really at the core of trauma-informed practice. And from there, many of those other really excellent principles of trauma-informed care. I do a little bit of a workshop with Dr. Mandy Buss for the undergraduates in medical school on trauma-informed care. And of course, at some level in our ancestry, in our lives, we've all experienced trauma in one form or another. However, we also know that trauma is ongoing and generational, and there's so many things I'm sure that many of our speakers will address that. So tonight, I just want to say Kina Naskamit now. Thank you to Gizi Manitou, creator, for this beautiful life that we have been given, this gift of life. We acknowledge this beautiful day that we have today. And in this holy time of the year, as we're coming into a new time, a springtime, a renewal of life. And even though we know that there are so many horrible things that are happening in not only the global community, but also within our own community, that we also have to have hope and that things can change and things can get better. So tonight I acknowledge that grandfather. We call the sun our grandfather, and we know that they kept their promise to travel that daytime sky to bring us light and energy and healing in that. We know that the sun gives us good energy, good spirits. And we also acknowledge at this time that grandmother. It just kind of breaks my heart that our Nokomis, our grandmother of all grandmothers, that's how we refer to the moon, is going to be under assault herself tonight as some space junk crashes into her, and it kind of is disturbing to me on so many levels, including on a very spiritual level, because that is the grandmother that we gather with every month during the full moon to ask her for her help and to intervene on our behalf to the cosmos. And we acknowledge her because of her incredibly important role of taking care of all the waterways on Earth, including the water that flows within our own bodies, and always acknowledge those grandmothers that work for the water, that have done so much to educate people about the sacredness of water and how important that water is for all of us to have, not only in the present time, but for those that are still coming to this earth, because they all will deserve fresh water to drink. It is a fundamental to life. Acknowledge that all of the things in creation are that have spirit are all also connected to us in very intricate and necessary ways, that without the trees, without the plants, without the animals, without all of that, that life as we know it wouldn't exist. And so we acknowledge that is a creator's law that connects us to all of those things. And tonight, you know, I just ask our ancestors to be with us, to sit with us, to guide our words and our thoughts and our questions, and to keep us in a connected. I know sometimes it's a little hard to connect via a technology, but it is what we have to work with, and thank goodness for that during these past 2 years. I know that coming out of these past 2 years has been very traumatic for many, many people in many, many different ways. And so we are going to reemerge into a world that our human species will have definitely experienced the trauma of all of that, all of the fear, all of the unknown, all of the interruptions in relationships, all of the losses that people have experienced. So all of that we ask that those that are suffering now in trauma are feel that they are important and connected. And so with that, I would like to ask just the Creator to be with us, with us, and guide our work this evening. Nadinawe Magaraduk, we are all related. Miigwech.
Thank you very much, Leslie. Next, we'd like to welcome Dr. Neetha Dick, Dean of the University of Manitoba's College of Nursing, to bring her opening remarks.
Thank you very much, Ashley. And thank you so much, Leslie, for your beautiful opening prayer and for your ongoing support of our students, faculty, and staff. It's really very much appreciated. Good evening, everyone. As Dean of the College of Nursing at the University of Manitoba, I'm delighted to welcome you to the 12th Annual Advanced Practice Nursing Conference. It is wonderful to see so many participants here this evening. Thank you for your interest and for joining us for this special conference. I congratulate the Graduate Nursing Students Association for organizing and hosting this special conference, and thank the Planning Committee for their excellent work. And a special thank you goes out to Ashley Bell and Hannah Mohammed as co-chairs of this Planning Committee. Given that most of our graduate students are working while studying, it is a huge accomplishment for them to have hosted this conference for 12 consecutive years. So we really congratulate you on your excellent work. Furthermore, you've made this initiative, this conference, a provincial event, and so that is quite remarkable, and congratulate you on that as well. I would also like to commend the co-chairs of the GNSA, Bon Alvarez and Vanessa Balin, and the entire executive for the excellent leadership you are providing and your active engagement in a range of very impactful initiatives. In particular, you took the initiative and assumed your role with the GNSA during a challenging time of a pandemic, and you've done it well. So thank you so much. The APN Conference is addressing a very important topic, that of trauma-informed practice. Advanced practice nurses play a key role in providing trauma-informed care in their daily practice. APNs also have many opportunities to influence the introduction of trauma-informed practice and ensure care is provided in a way that acknowledges the impact of trauma, addresses the needs of trauma survivors, and prevents re-traumatization of patients and staff. So I look forward to learning more about trauma-informed practice from our special guests this evening. And I extend a very warm welcome to our 4 panelists, including our very own Dr. Nicole Harder, Jessy Dame, Rhonda Campbell, and Jennifer Cumpsty. And I want to thank each of them for their exemplary leadership they're providing in their unique role and for their contribution here tonight. At the College of Nursing, we are very privileged to have the opportunity to provide graduate education and prepare advanced practice nurses for their critical role within the healthcare system. We have delivered our graduate programs for more than 40 years and are proud of our more than 600 graduates from the program. Our master's program has 4 streams of administration, education, clinical practice, and nurse practitioner. Our PhD in nursing program began in 2013, and we're proud of our 9 graduates to date who are providing exemplary care and leadership in the healthcare and education systems. So I'm very excited about tonight and about learning more about trauma-informed practice. So thanks again for coming and enjoy the evening.
Thank you very much, Dr. Dick. Our first guest speaker is Dr. Nicole Harder, who is an associate professor and an associate dean for the undergraduate program for the College of Nursing. She is also the Minderman Professor in Human Simulation for the Rady Faculty of Health Sciences here at the University of Manitoba. Her research work focuses on promoting resilience and coping strategies among new practitioners through psychologically safe debriefing methods and simulation. Please help me in welcoming Dr. Harder.
Thanks. With the little claps, it's kind of, they pop up. So I'm just going to put my timer on because I get very passionate about this and can take us till 8:30. And I'm sure we don't necessarily want that because we have another wonderful group of speakers that I am more than happy to hear about their work as well. So thank you again for that introduction. So you can probably assume that I am primarily an academic and an educator. And so even though I might not necessarily be in practice and at the bedside as some of my colleagues are, what my work primarily involves is, as my introduction was, is in simulation. And so what that means is it depends on what kind of simulation. There's so many kinds. And so what we do at the College of Nursing is we have simulation that involves human patient simulators. So those are the computerized mannequins. But what we also do is work a lot with simulated patients or also with virtual simulation. So there's a lot of different types of activities that we do. We also have a fairly robust simulation program. So we have approximately 25% of our clinical practice hours being replaced with simulation experiences. So that means that our undergraduate students, before they graduate, will go through anywhere between 75 to 80 simulations before, like I said, before they go to senior practicum. So that's a lot of simulation. When we started, I'll be honest, most of the simulations were kind of med-surg or emergency or prioritization, which are all very important. But what we were finding is that we were really good at the management of patients. But as we became better, I'll say, at conducting simulations, we started to explore more of the human side of interpersonal communication. So we had more simulations that included things like patient death, ethical situations that included rights to refuse care, suicide assessments, pediatric death. So some of the simulations started to be a little bit more emotional or psychologically stressful events. So as we work through them, we always debrief every simulation. So after you have completed that, the simulations themselves generally have a set of questions. And the questions are really designed to look at making sure that we were able to achieve the learning outcomes. So the debriefing frameworks are very much based on education models. And so, as I said, they really look to debrief have we been able to achieve the learning outcomes? Were we able to meet our objectives and so on? But when we were looking at creating or doing these simulations that were more emotionally or psychologically stressful, that didn't quite fit. We didn't have outcomes to say, okay, this person reacted appropriately, because that is so dependent. So what myself and a small team looked at doing is, how can we debrief these, where rather than look at the educational outcomes, really look at starting to address some of this emotional and psychological stress that people were experiencing, because we have a great opportunity to do so. So with my team, there was myself, another colleague that works in mental health, another one in palliative care. We involved a clinical psychologist, counseling, and we created a trauma-informed psychologically safe debriefing framework. And the reason we did that was so that when we debriefed these events, it was less about what did you learn, but more how can we help students identify what are normal reactions to these kinds of events? What are when are times that you need to seek help? What is, and sort of normalize some of these experiences, because we were, like I said, putting them in situations that had this additional stress. So what was really interesting as we started working through that is we became a little bit more bold with the kinds of activities that we could include. Meaning we initially, a lot of people stayed away from anything that included patient death. If you looked at the literature in simulation, there's a whole plethora that will say, do not have your mannequin die, do not have the patient die in a simulation, because it will be stressful for your learners. And we chose the different approaches. Rather than trying to shelter some of our students and not have the patient die, why don't we work with students when they are in this formative sort of stage and learn how to respond to these, how to identify their feelings and emotions. So rather than the old way of thinking, I'll say, is when you just, cram all your feelings down and don't cry about anything, and there's no tears in front of patients and all that kind of stuff. Just to realize that that's not, first of all, it's not realistic. And second, it's not healthy. It's not healthy for you as a student, and it's definitely not healthy for practitioners. And I'm sure you've all probably been in situations where they have been, very, very emotionally stressful clinical situations, and your feelings are right there at the surface and you don't quite know what to do. And yet your first response is just, bury them all deep. Don't talk to anybody about them. You don't want to be seen as weak, and all those other kinds of very unhealthy things we've been told over the years. So by including this in the undergraduate program, we're hopefully able to, like I said, start to develop some of these coping and resiliency skills, and to role model them with students while they are in those formative stages. And rather than saying, you don't cry in front of your patients, which of course, we're not saying have a, bawling, but tears are normal, and tears are part of what makes us human, and that we need to embrace that, but also to be able to sort of understand, as I said before, where we are, when we might need a little bit more assistance. So as I said, we created this trauma-informed psychologically safe frameworks. We call it TIPS for short, because to say it all the time is a little bit of a mouthful, and started to use this primarily with our end-of-life scenarios. So when we knew there was patient death that was occurring, and there's a whole, and I won't get into that, but there's a whole process that's in place. So that way we let students know what's going to be happening. There's no surprises for them. It's really an opportunity to, start to feel what it's like to be in these situations, as opposed to throwing students into, or once they graduate and then being thrown into these situations and not really having that exposure, those opportunities to learn how to address them. So as we got, as I said, more comfortable with that, we started to expand that to include situations where we had more things like bullying, horizontal violence in nursing, as well as looking at racism, addressing racism and stereotypes that people are experiencing. And so really trying to push these experiences so that way, again, we can unpack them when we're in the simulation environment, as opposed to the clinical environment, which we know can be very, very hectic and very chaotic. So for example, if our simulation is 20 minutes, the debriefing is probably half an hour. And so we spend more time on unpacking that and addressing that, as opposed to just, rushing to the next activity, which often is the case. And in our simulation environments, they are fairly small. So you have a group of maximum 10 students to one instructor, oftentimes are smaller. So that really, again, gives us the opportunity to work with students at addressing these. And just before the pandemic, we were starting to look at potentially at doing a pilot with our new staff from Health Sciences Center. We had a grant funded through Health Sciences Center to look at new graduates who are now going to be transitioning to practice, and again, addressing some of these highly stressful environments or highly stressful types of situations before they get out into practice. So that's been a bit on hold because the nurses out in practice have been a bit busy lately. And so, but definitely something that we want to pick up on as we get going with that. The other thing that we've also identified is when we're looking at trauma-informed care, we don't know what people are coming with to these experiences. So with over 120 students, let's say in a term, that are going through simulations, just like those of you here, I don't know what kind of experiences you've had. I don't know what kind of past traumas you've had. I don't know what your potential triggers might be. And so what we also include is a safe word in our activities. And the purpose of that is to allow students, and we tell everybody what the safe word is. It's phone booth, which really doesn't mean anything to anybody anymore, but it's a word that we all know. And what that does is it allows, if the student uses the safe word, it allows them to sort of remove themselves from the simulation and be maybe more of an observer, still be part of the debriefing, but not be an active participant in the simulation. Because what we really don't want to do is re-traumatize students who might have these other kinds of experiences. So we've been really cognizant of that because, again, that's an important part to, as Leslie was saying, is some of those previous traumas, we don't know what they are, but we definitely are going to try our best not to re-traumatize them, especially if we know we're going to be putting people in situations that have the potential to do so. What that also means, what we're doing is, some of you might have done some of the virtual simulations if you've been involved in our nursing program more recently. What the benefit of virtual simulations are is, again, going back to some of the horizontal violence simulations or on racism and stereotypes, is we do need to have representation from various groups to make these really authentic. It can't continually be myself as a standardized patient who is a middle-aged white woman. I mean, there's a lot more diversity than that. So we need to make sure we include that in our simulation experiences. But also, I don't want to put different individuals in the situation where there are standardized patients or simulated patients who are reliving these traumas just for students to learn. That's not what we want to do. So we are looking at creating more virtual simulations where it's essentially a video simulation, and there's different options and where students can go with that simulation. But then it's sort of a one-time investment in creating these, but yet the way that we can debrief them and problem solve through them and address some of these very emotionally or psychologically stressful events is another way to ensure that not only are we keeping the students safe, but also any of our simulated or standardized patients safe in those kinds of environments as well. Because again, we don't know what people's past history or traumas might be. So it's interesting because, again, my world, I said, is simulation, but we often think that instructors or simulated patients, whoever's there to do the instruction, that their job is just to do that without necessarily taking into consideration what their history and their traumas might be as well. So it's definitely evolving, but at the same time, it's the most, for myself, the most meaningful work that I think I do, because you can really start to, like I said, develop some of these coping and resiliency skills that are so important for our new nurses as they're moving forward. I mean, and I know you're grad students, but if you think back to your first year or two of being a new nurse, it's scary. You're put into situations where you don't know how to cope. You don't know what you're supposed to feel, what's normal, what's not normal. I mean, it's great that we have a counselor here with us, because these kinds of situations can be very traumatic, and we don't always know who to turn to. And often, don't get me wrong, I know we might have a incident response team who will meet with a team Tuesday at 9 a.m. or whatever, but sometimes people need to be able to just do that self-debriefing or the self-reflection immediately after a situation occurs. And again, those are things that we work through with students. So I just wanted to share that with you, or thank you very much for the opportunity for allowing me to share that with you, because I think when we think back to nursing education, we think of the med-surg courses and the theory and the fun times that we spend in the skills lab with the mannequins and everything else. But yet there's so much more that can occur in our education experiences that we have the opportunity to do. And I think by including more things like this, we'll hopefully have a student who's a little bit more better prepared than I know definitely I was when I graduated from nursing 3 years ago. I'm not even kidding. It's been 25 years, but anyway. So I just wanted to kind of leave you with that, just to share that. And so I don't know if you have any questions or how you wanted to handle that, or if we're moving on.
Thank you for that wonderful presentation. We're now opening the floor for any questions that anybody has for Dr. Harder.
Feel free to use the hand raise function. Go ahead, Christine.
Sorry, hi. So that's a very interesting program. Thanks for your presentation. I'm just wondering, it's important work to do, but what kind of considerations did you have to go through for like the research ethics? Well, I guess maybe it's not research, but like the ethics board at the university and things like that, to get more of the stressful psychological situations in the simulations, or did you have a problem with that?
We so now Natalia, who is invited to be here, her predecessor was heavily involved with us, and we made them very aware every time we were running these simulations. So that way, if there was any students that were experiencing that kind of emotional or psychological stress, we had essentially, he booked off, that was the appointment, was to attend to our students, because it's important to be able to have somebody readily available immediately. And so again, by having that safe word, that kind of gave us the opportunity, that's sort of the first stop, I'll say, is saying, okay, we'll remove you from the situation. And then if that was not enough for the individual, if they were still feeling extreme amounts of stress and anxiety, then we would involve people like Natalia in these. So that was the operations, like the day-to-day management of that. Ethics is a little bit different. And so that also involved having someone available, but then your purpose is a little bit different. So we tried to, with the ethics piece was more the creation and the initial piloting of that. And once we knew that we had sort of a process in place that kept, from our learners' perspective, kept people feeling comfortable with the process, that's when we rolled it out a little bit more with the students. And in person, because with the pandemic, we haven't been able to necessarily do that in person. There's still like anything, there's always more work to do. We haven't been able to do it as much because, as you know, it's not the same through virtual. I mean, we can do a lot on Zoom, but it's not quite the same. So I'm very much looking forward to getting back to that in the fall and seeing. Having said that, I also know that people are going to be more stressed and more anxious in the fall. So there's going to be even more attention that will be need to pay to that. And so we might pull back a little bit on that, just because I think you know, sometimes people going into it, they're already going to be at a 4 out of 10, as opposed to normally being, you know, a little bit more relaxed, I would say.
Thanks.
Looks like we have a few questions in the chat here.
Yes, I'll read them if you'd like. Ashley, is that okay? I was just waiting to see if
Perfect.
anybody had their hand up first before.
Perfect. No,
All right.
go right ahead.
The first question is, do you have research studies or articles regarding trauma training for nursing students to share?
Okay, trauma training for nursing students. That's for research articles. So the short answer is no. And I would just kind of want to know a little bit more. Are you looking at the students? So I guess what I'm wondering is, what are you looking for? So for example, are you asking whether there are resources for students who are experiencing psychological stress or emotional stress? Because we do have a lot of that. Or is it that you want students being more informed in how to be, you know, part of that? I'm not too sure what the
question means.
Yeah.
It's from Lindsay. I don't know if she wants to type something in and I can come back to that, or if she'd like to speak with the microphone, I'll let her. There is a comment after hers that said Red River College has a trauma-informed care class available in the nursing program, but it's unfortunately elective, so students have to choose between the others. So I'm not sure if that's what she was looking for as well, but I'll give her a couple of minutes to
Hi, this is
answer.
Lindsay. I was just wondering if you had, from what you're telling us today, regarding how the trauma-informed practice in this situation, do you have research that's based on evidence-based? And if you had that, do you have anything to share? That's all.
Okay, sure. Yeah, so I do, and maybe what I'll do is I'll send it to Hannah and I'm not too sure who else would want that, but I was going to say, or Ashley, both of you. And so what it is that when we created this, we initially did a scoping review to look at what are the most effective debriefing frameworks following. It was focused primarily on patient death, both expected and unexpected in clinical and or simulation environments. So we have that initial one, and then how we created the debriefing framework. We also have additional literature on that. If you're specific to this type of work. The area of trauma-informed care itself is very, very large. So that's why I would want to know a little bit more what you were looking for. But I will send what I do have to Hannah, and then hopefully we can send things along.
Thank you.
All right, there's another question from Catherine. It says, Nicole, do you run the death and dying simulation in year 3 of your program? And then she says, we've had some discussion at Brandon University whether this should be incorporated in year 2 or later in year 3 or 4.
Right, so for the most part, things are going to be concurrent with whatever they're taking in their theory classes. So death and dying palliative care for us is in year 3, term 1. And so that's where we would find that those simulations. So having said that, though, there are some that might be in year 2 that might still be somewhat stressful. Death, especially pediatric death, is the #1 reason for psychological stress amongst, and that's not just me, that's according to the literature. So it's, you know, those are ones we know are going to be like that. But the thing is that, again, because we don't know what people's past experiences and our triggers are, you might have a basic, and I'll call it basic, heart failure scenario running in a year 2, term 1 program. And I don't know that the student just had a family member who had heart failure and maybe had some sort of traumatic events around that. So even though we have ones that we know are potential, we treat every simulation as though there is that potential, which is why we have the safe word in there. So I would just, you know, maybe Catherine and I can chat a little bit more about what that, some of the rationale about putting them in either or, because there's something to be said to having these exposures, like micro exposures early and consistently throughout the program, if what we're trying to do is develop coping and resiliency skills, as opposed to just put everything at the end. That's a little bit too late sometimes.
Okay, thank you. I think this sort of goes with one of the other questions, but I'll read. Are there any opportunities for continued education training simulations?
Oh, there is a lot. So maybe what I would recommend is to just get in touch with me, because there are, even through the Canadian Association Schools of Nursing, there are programs through there. There's a lot of other, I'll call them kind of workshops or micro courses that are available through some of the simulation organizations like INACSL, the International Nursing Association for Clinical Simulation and Learning, through Simulation Canada. So there are quite a few. And so if it's something that you're interested in, just send me an email, or I can again send it to Hannah and Ashley, and they can circulate that.
And I just actually had one quick question if we had a chance to ask. I just find with death and dying, just from my experience with nursing and such, that it isn't something that people are comfortable with, even if they have lots of experience. Do you find that doing this helps with their communication skills and just coping with how to speak to families and residents or patients?
That's the hope, right? Is that we would be able to have people. You're never going to feel 100% comfortable,
Yes.
because it is a very, for all of us it is, and even myself, it's very interesting, because I don't consider myself an overly emotional person, but when we're doing these simulations, sometimes we'll have the standardized patient is crying, and then the student is crying, and before you know it, I am crying, or we're all crying, and it's just one of these. And I don't want to say that I don't want to minimize that. I want to say that that's just how real these can be. And there's a mannequin that's there that has this monitor that just has a asystole on it. So I mean, there's not even a real person, but it's just how just having emotions as part of these experiences just really they're so memorable. They're so memorable. So. I mean, again, I don't think you'll ever quite get 100% comfortable, but at least not running away from it, and start to address some of that is what we're trying to explore with our students.
Thank you. I think just the exposure, just having something, right? Yeah. Thank you very much. There is no more questions. I'll pass back to Ashley.
Great. Thank you.
Wonderful. Thank you so much for that great presentation, Dr. Harder. Her email address is in the chat for anybody that would like to pursue further questions. Our next speaker is Jessy Dame. He is a registered nurse who works in a queer sexual health clinic in downtown Vancouver, and he is a Two-Spirit program manager at a community-based research center. Recently, he joined the Vancouver Coastal Health Team as the Indigenous Sex and Gender Lead. Please help me in welcoming Jessy Dame.
Thank you so much, everybody. I am going to attempt to share a presentation in the timeline, so we will see how that goes. Just wanted to start off by thanking Elder for the opening, and I'm very happy to be here this evening to have some of these conversations. I think as nurses, trauma-informed care needs to always be at the forefront of our mind, and that includes assumptions in language. So that's two of the biggest things that I talk about in this conversation about decolonizing the binary within birthing. I speak really fast, so I apologize to some folks. I will try to slow it down, as well as I'm going to briefly cover a few major concepts and then kind of unpack it and hopefully open it up to a longer question period. But I know it's a tight timeline. So first, I'd like to just acknowledge that I am joining from the traditional unceded territories of the Coast Salish people. I currently reside among the Katsi, Samiamo, and Kwantlen First Nations in what we now know as South Surrey in BC. The purpose of a land acknowledgement, I think, is extremely important for me just to also reiterate from the teachings that I've gotten. It's really important to provide a land acknowledgement in our presentations, not as simply a tick mark, but a way that we are able to reconnect with ourselves and the responsibility that comes from the learning that we're going to gain from the presentations this evening. So really that moment to connect and grab hold, and then to continue to learn and acknowledge that we have a responsibility of folks who occupy this land, and with the education and the advocacy that we have as nurses. So again, who am I? So actually, I am very proudly Two-Spirit and Métis. I actually come, both my parents are Métis and originally from Treaty 1 and Treaty 2 territories. So actually from Manitoba, both my parents, though I was born and raised in BC. So my family is from Winnipeg and my mom's side is from St. Rose-de-Lac. So both my parents are Red River Cree and moved here before I was born. I have a brother, who am I? And I have recently added a brother. And Nicole, to your point, I lost my brother 3 weeks ago to the overdose crisis that is happening in our country. And this is an extremely heavy time, and a point that I am working very hard to acknowledge my brother and all the work that we do. And a lot of my work is in harm reduction, and a lot of it is very triggering and very difficult, but it is also my responsibility and my dedication to my brother to continue to fight and advocate for Brendan. And I say his name very proudly and with honor, and continue to advocate every day for him. So as a registered nurse, I wear many hats, as they said. So a part of my job is I'm a certified sexual health nurse. So in the province of BC, we do have certified practice or expanded scope, where I'm able to diagnose and treat folks within a queer sexual health clinic setting. I'm also in a nonprofit called CVRC, or the Community-Based Research Center, which is a queer research organization. And we do a number of different queer research pieces, and a brand new position within Vancouver Coastal Health as a leader in gender and sexual health. So all those hats are related to the presentation I'm here today. And as I said, I am an uninvited guest on these lands, and I've been on the path of reclaiming my Métis identity my entire life, but very intensely over the last 15 years, connecting with Métis communities in the province of BC, as well as back in Manitoba. So, okay, now I'm gonna get right into it, okay? So quickly, the concept of decolonization. I'm sure most folks, especially within the folks who are calling in today, know what decolonization is, but basically it's restoring Indigenous worldviews. It's about shifting the way Indigenous people view themselves and the way non-Indigenous people view Indigenous people. So it's really restoring the cultural and traditional ways, challenging the view of Indigenous people within all contexts. What does that mean in healthcare? Is it creating space? Actually, no, it's giving back space that was taken. And I think that's one of the biggest shifts in view that we have to acknowledge, is that we shouldn't be so proud of ourselves about creating this space. It's actually our responsibility to give and advocate for that space back. Increasing visibility. What does that mean? Is that simply putting an image on your wall? Actually, no, because if we're just putting plaques and stickers, we've really clearly seen that that is not what true allyship is. And it's very different in actually giving back spaces and creating safety within our work sites and as healthcare providers. And unfortunately, we still have a very long way to go in regards to decolonization within my presentation, the binary, but also within our healthcare system. Quickly, again, another concept, the binary. So as per the Webster Dictionary, the simplest way to say it is consisting of, indicating, or involving two things. So just two. So in current state society, the binary centers around all human beings being either a man or a woman. It's a very much a Western construct, and we now know that throughout Turtle Island and actually the entire world, which I'll expand on it a little bit more in a moment, there are many, many communities with many genders and different forms of gender expression. The binary was created purposefully to divide and disempower folks who do not fit in within the societal mold. So it was a purposeful tactic to disempower folks and strip them of their strength from coming and being strong human beings by forcing us to conform, to assimilate into a specific identity. I think a big note that people get confused about sometimes is the difference between sex and gender. So when we're talking about sex, we can talk about, we're talking more about body parts, as well as it can be indicators as being male or female. And then when we talk about gender, that's the factor that's this very large spectrum that can include many different identities, many different concepts, many different beautiful things. Man and woman is a part of that, but so are non-binary folks, trans folks, a number of different people, depending how their gender expression is. And then the beautiful thing of being two-spirit and as myself, just to quickly dive into this concept, and then again, relating it back to the most important pieces is about assumptions and language. So two-spirit is a community organizing tool and not necessarily an identity. So this is a big part that I urge us all to really reflect on, is this configuration of an identity versus the concepts of gender and the broader picture. So many people, and within healthcare, unfortunately, we are forced people to fit into certain boxes and really define ourselves and really pressure people to define ourselves as one thing. And this is where I really hope folks can push themselves and really dive in deeper into some of that beautiful fluffy stuff that I used to make fun of in nursing school, unfortunately. Now realizing 10 years later, that was the most important stuff, really pushing those boundaries of challenging my internal forms of homophobia and discrimination as a queer person that I've learned from society, and that actually we don't need to fit into certain boxes. And by actually expanding and going outside of these specific binary boxes, we actually can find out more about ourselves and become stronger and confident beings, or more confident beings. And comes in within the Indigenous specific community, the term and concept of being two-spirit. And that really is a term that has come into place over the last couple of years. And it's it's really difficult to make sense outside of an Indigenous framework, but it was more about your responsibilities in community than your genitals or who you were having sex with. And I think this is one of the biggest frustrations with being current day society is we are always worried about people's genitals and who they're having sex with, instead of actually talking to folks about how they're feeling and their expressions. So I think that's a big piece that we need to shift in society. But again, Two-Spirit is consistently associated currently with the LGBTQAI+ spectrum, but it's not necessarily a sexual orientation. It's not necessarily a gender identity. It's both, as well as much more. And every expression is different. It's fluid, it's beautiful, it's powerful. Unfortunately, our system doesn't love that because it doesn't fit into a box, as I'm saying. It's directly tied to my indigeneity, but it's also directly tied to my conceptuality of my gender, as well as my sexual attraction, as well as my responsibility as a Two-Spirit person, which is actually doing this work. So as Two-Spirit people, I'll actually dive into it in a moment. I'm getting ahead of myself. So briefly again, before Two-Spirit, there was a term from during colonization, there was a term called bardash, which is a super homophobic, super problematic term. So I use this term because it is actually still found in research today, which is super problematic. It's a very troubling word. So because of that term, in the 90s, it came together actually in Winnipeg at an international Two-Spirit gathering, or at the time, an international LGBTQ gathering, the term Two-Spirit was coined. Prior to 1492, there was thousands of terms for folks that were Two-Spirit. And again, it was more about their role in community than their genitals, than their people they were having sex with. So roles that define folks as Two-Spirit were all of these pieces: mediators, name givers, Sundance people, joined war parties, were doctors, medicine people, healers, and really folks that had to navigate and to support the community. So it was actually seen as a beautiful responsibility and a beautiful honor to have Two-Spirit people a part of their community, which for me was truly the first time that I really experienced how healing culture could be, how I could connect to something that I didn't even know I was missing and truly feel that weight being lifted off my shoulders. And that's when I really started again to buy into, through my own personal experience, being raised in a pretty traditional family and Western way of nursing, didn't really connect as deeply as I do now to the self-care and the love aspects of myself and how that actually comes out in my nursing practice. And terms actually aren't unique to Spirit, though it is an Indigenous specific term. Again, Indigenous specific, it is a term that is used for Indigenous folks only of Turtle Island or North America. There are a number of different terms that are quite similar throughout the world. So this concept understanding and the understanding that there is more than one gender is not unique to Indigenous people of Canada, which is one of the biggest realizations for folks, that this isn't a unique thing. This is a normal and very beautiful thing throughout the world. Unfortunately, through colonization and a number of different factors, we've limited it and added barriers. I'm just aware of time, so unfortunately, I'm going to skip a few slides and just go into the part that I really want to discuss tonight, which is language matters. And just really wanting to dive into the fact that it is extremely important for us as nurses to really reflect on the conversations we have with patients and giving back space for folks to identify themselves. So right now, I mainly work, my background is in the NICU and within postpartum health. So a very genderized area of practice, which is a beautiful place, but also an extremely harmful place for folks who don't conform to the spectrum of being a woman and are giving birth. So there's a lot of work being done, thankfully, within my team to support folks who are either trans or non-binary or fit within different spectrums of gender that don't completely conform to this very gender-based practice. And it's an interesting conversation that we're having. And I think it's time for us to really reflect on what we're trying to do. My main goal, end of day, is to create a kinder environment. And if we can decrease discrimination towards queer folks, we're decreasing discrimination for all folks. If we can decrease racism, we're bettering the environment for all folks. And I think we need to challenge that singular piece and really realize that if we're taking away discrimination, we're creating a kinder environment for everybody. Everybody benefits from an environment with less discrimination. So additive language. This is a common tool that's happening now that I would strongly urge folks to reflect on. Women and other folks who give birth, women and other people. What are we really normalizing in those conversations? We're still normalizing women and everybody else. So we're really not actually trying to be inclusive. We're still singling out the norm and adding everybody else after. If we want to list out every single gender, I give you the power, but Or we could create a space or give back a space that is a lot more neutral and challenge the norms that we're talking about. We should be talking about birth work and the folks who are giving birth instead of really focusing on gender language in literature, or we should be having the conversations with our patients. Create that space where folks can identify to you. And if they identify as a woman, great. If they identify as something else, great. Let's make sure we document that and create an environment where we know that the nurses following up and the nurses caring for these patients afterwards are going to abide by those requests by the patient, including the difference between chest and breast and a number of different languages that are used within the birthing floors that can be very harmful or triggering to people. And I think that's a really important factor for us to reflect on. And in my mind, could be a simple change, but it does take some work, and it is some challenging of some internal ciscentricity, so focusing on everybody's cisgender, some heterocentricity, focusing that everybody's heterosexual, and really challenging some of those internal factors that society has forced upon us and what that looks like. I think one of the biggest factors that, and my last point, because I know we're out of time, I think I'm pretty close to time. I think Ashley, right? I need to wrap it up.
A couple more minutes, don't worry.
Okay. One of the biggest points that I think, especially as folks doing their masters and other pieces in regards to research, is one of the most important parts that I can stress: statistics and numbers and majority views. So when I'm having these conversations about birth work and the binary within birthing, it's extremely unfortunate the number of folks who say, well, it's such a small percentage of people, like why are we catering our environments? Why are we even doing this work? And in my mind, it's our responsibility as folks who are privileging from the many privileges, but B, also, wouldn't it be better just to have an environment that's safe and kind for all folks instead of majority of folks? So it's this majority view. The conversation can continue down. So I like to break it down in a way. So as a Two-Spirit person, I represent about 0.002% of the population in Canada. So that's about 70,000 people. That's a lot of people if you really want to think about it. And let's talk about discrimination. So 50% of that 70,000, so about 35,000 people, are likely to die due to racism, discrimination, and homophobia. So now we're talking about the deaths of 35,000 people because of this societal view that pegs us as abnormal, as different, and people not wanting to reflect and adapt their practices or their language a little bit to create a safer environment. And if the death of potentially 35,000 people, which actually the rates are much higher, unfortunately, right now, isn't reflexive enough for you, then I think we should have other conversations about empathy and compassion towards community groups. And it's really about breaking the numbers down and not hiding behind statistics or majority view, because the majority view was created to silence the minority groups. I don't even like saying minority groups, but silence the smaller numbers. And then we're seeing, because we're smaller numbers, as not big enough to have views, which then continues to silence us again and again and again. So it's a really important point to reflect on when we're doing research, when we're wanting to include folks, when we're servicing communities and really looking at the smaller numbers. Of course, Two-Spirit people there's gonna be 5 for every couple hundred non-Two-Spirit people. Does that mean they should be left out? No, but we have to have the conversations about how do we create safe pathways for those folks to be included and not excluded because their numbers were too small. And that's a huge factor that I noted when I was doing my master's at UBC, and some of the research that is more specific to Two-Spirit people is that the subgroups or the cohorts of Two-Spirit people were always so small that they were collapsed and absorbed in different ways and never really got the visibility or the presentation that they deserved or needed because their numbers were always too small, because the system has made them so small. And it's just a system that never really ends. And I think for my last, I guess, one more point in regards to my research is I really focused throughout my master's findings on protective factors. So really challenging that risk factor language. I found in majority of the articles that I was reading about queer and Two-Spirit men who have sex with men, the first sentences were basically telling me how I would die, how I would infect specific diseases, and how all my identity and my conceptual understanding of who I was were the risk factors instead of the homophobia, racism, or discrimination that is in society. So I really wanted to flip that narrative and really focus on what protected me to be here today, and found that in my small cohort in my master's findings felt the same way, and that protective factors were more focused. And a big part of that protective factors was connecting with healthcare versus connecting to healthcare. And that single word was the difference. We connect to many things. We connect to our computer, we connect to different things. But when we connect with something or we connect with our healthcare provider, that's when we really set that standard that we visualize our patients as human beings, as complex human beings with trauma, with experiences, and we need to really invest. And I know we don't always have the time, don't get me wrong, as a practicing nurse, I understand the time constraints, but we do need to set a standard of opening up places to have conversations with our patients about pronouns, about gender, about sexual practices if it's relevant, about these pieces, so that we can connect with folks and create a space or environment or healthcare setting that is really open for people to express themselves in a whole. Yeah, I will finish there. I'm sorry that for some reason, I thought my presentation was 35 minutes, not 15. Clearly, I didn't look at the agenda, but I will finish it there and open it up to questions if folks have any.
Thank you so much, Jessy. If anyone has any questions, feel free to put them in the chat or raise your hand. We'll start off with Maeve.
Hey, Jessy. I really liked your presentation here. I'll turn my video on. I don't know if it'll work. I'm in Northern Ontario and my computer is kind of funky sometimes. I loved what you were talking about connecting our patients with healthcare. And like, sometimes I find that we can act like healthcare in itself is a binary. Like they're just accepting what we're telling them, or we are they're telling us one thing and we're just accepting that instead of having it be more of like a conversation. One thing I would say though, is I've been talking a lot to other providers right now. I'm in NP school right now, and I'm working with lots of providers at this point, doctors and other nurse practitioners. And one of the things I do quite often is cervical screening. And I have provided cervical screening to folks that are not, I guess, identifying as women. And for me, like one thing that stood out to me a little bit is you saying that like, oh, be careful about your language with like calling someone with like a chest, a breast, or whatever. For me, what I've always found to be more useful is like asking what they'd like me to call their parts, you know, because some people are worried about their menstruation. Other people don't mind talking about it. Some people don't want their cervix to be called a cervix. Other people really don't mind. And I think it's, you know, it can be tricky for some providers to talk about this kind of thing, you know? And I think that like kind of saying, oh, don't say it like this, you know, it kind of shuts down the conversation a bit. I don't know, that's just one thing I kind of noted. I don't want it to be like a negative or anything. I just, I don't know, I just really connected with what you're saying, like connecting with healthcare. Like, anyway, thank you so much for your presentation.
Thank you. And I don't know if I should never meant or did not mean to say, do not say certain words. The key that I was trying to say is to have the conversation with folks to identify what they would like and what body parts and how they would like their body parts to be spoken about. I'm not meaning to say, don't say breast, don't say chest. Have the conversations with your patients to determine what body parts what they would like to call the body parts that they have, and what pronouns and gender expression that they have in creating that space. So sorry for misspeaking, but I completely agree. It's about having a conversation.
I don't think you're misspeaking at all. I just wanted to like kind of clarify a bit, because like I just feel like I have some talks with people about these kind of things, and it can be difficult for folks to wrap their head around kind of some of these concepts. Totally. And I want to include people in these conversations so that we can, like you said, you know, make sure everyone is included, not just, you know, the majority, right? And those majority folks sometimes need a little bit more help, unfortunately, to get there, right?
Yep, totally. And I think one of the biggest factors, especially in the realms of birth work and stuff, is the understandings of different forms of oppression and privileges that come with the different pieces, right? I do identify as Indigenous, but my fair skin provides a different privilege that my indigeneity doesn't cover. And I think my identity, like my presenting as a man, overdoes my privileges are very different, and it's being very aware that certain privileges come with, and of course, with responsibility. And this is a big conversation I have within birth work, especially when it comes to trans exclusionary radical feminists. So I don't know if folks have heard trans exclusionary radical feminists, but there is some folks who believe that we should be creating space that doesn't include trans folks, or that we should be really genderizing certain folks, because for so long there's been a huge advocacy for women to be present in a lot of this work. And that's not to take away from that feminism that got us to the path we are in within nursing. It's to add to create those alternate pathways for folks who don't identify within that spectrum. And it's this interesting turf battle sometimes, which is extremely unfortunate because it does cause a lot of harm. That come with that, and we have a responsibility to not assume and to have conversation and build relations. Key result is just to build relations.
Thanks so much. I think we have a question from Jess.
Yeah, hi Jess.
Hey Jessy, thank you so much for doing this. This has been fantastic.
Thank you.
I'm wondering for the group who might not know, but where is the spot that you might recommend where people can learn more about this topic or this language? You mentioned the word cisgender, and that might be an unfamiliar term for people. So do you have any resources that you might recommend?
Absolutely. So mine are more specific to the BC, but they're beautifully able to use nationally. So I can. Yes, so Transcare BC. We also at CBRC are putting out a Two-Spirit language guide. So it includes many of the concepts that I talked about tonight, and more discussion on the concept of being Two-Spirit, and more in-depth history in regards to Two-Spirit, but also just the challenging the binary in many different ways. So I can send some of those resources on after for sure. And I think one of the biggest things that I need to reiterate as well as nurses, this isn't easy work. I make it sound like it just should happen. That's not the case. This is difficult work. We have a lot of internal pieces that we need to challenge. There's a lot of societal pieces that we need to challenge. And it is extra work for us. And I get that. And I want to validate that work and that responsibility, with the end goal being a kinder and safer environment for folks. And that I think we can't say one and not the other. So really identifying that this is extra work that all of us need to take on. And that can be frustrating, totally. And then the beauty of the end result, hopefully, will be a space where all of us feel welcome and can access care to our full expression.
Awesome. Thanks so much. I see in the chat we just have a couple thank yous, and Jess has posted the Transcare BC website in there. So
perfect.
There's no other questions. Thank you very much.
Thank you so much.
Thank you for that wonderful presentation, Jessy. Our next speaker is Rhonda Campbell, a nurse practitioner who works in the inner city of Winnipeg, providing primary and walk-in care to underserved populations. She is also the nurse program advisor for the First Nations Strengthening Family Child Health Program, and she has served as the lead researcher and co-led the development of the First Nations curriculum for safe sleep among Indigenous communities in 2013. Please welcome Rhonda Campbell.
Miigwech for that. I'd also like to say miigwech for the tobacco offering to participate in this important discussion. First of all, I'd like to acknowledge Elder Spillett in that opening remarks and her opening prayer to set us in a good way. So far, we've had two wonderful discussions, and so that's good. So bonjour Anin, Rhonda Campbell Dishnikaz, Bijou do dem, Minagosi B Donji. So I'm a band member from Pine Creek First Nation, that's in Treaty 4, but I grew up in Camperville, as a lot of my ancestors were from Métis. We know with those laws, you know, a lot of our women were disenfranchised at a time. And also a lot of the people had taken script. So I'd just like to acknowledge that's where I was raised. I'd also like to do a shout out to a few people that I see on here first. My sister Nellie, she's in Brandon. She's a psychiatric nurse and does a lot of work with the elderly in Brandon personal care homes. And also my co-workers, Bridget and Claudette, who are NPs, and Katie Swan. So I think those are the people that I recognized on here. Okay, so I have made a little presentation, so I'm just going to share it and just kind of go through it and kind of share my experiences. Okay. Wait, I think I have to open it first. Hold on. Oh, there it is. Okay, so I'm just going to expand that. Okay. So yes, so I was asked to speak on the APN role and trauma-informed practice coming from Indigenous perspective, or working with Indigenous people. And yeah, so a lot of this I had to do a little research, because even though I've been a practicing nurse for, I don't know, 34 years, that really understanding what trauma was, like I've been doing it, but didn't have the words for it, because when I graduated way back in '88, and you know, we didn't have this. So I'm, you know, so I've learned some new things. So I don't have any disclosures to report. This is what I wanted to kind of walk you through. And just very briefly, I think it's important to know who Indigenous people are. What's the definition of trauma-informed care? What is historical trauma? I think that's a fairly new concept as I was reading. And providing trauma-informed care and practice. And then some other references that I used to create this talk. So in Manitoba, Indigenous people or Aboriginal people, Native people, we have three distinct groups. So the first one is First Nations people in Manitoba. And there are 63 First Nations in within Manitoba. When I looked at the stats, there's approximately 164,000 First Nation people, but over 70,000 live in the Northern Health Region. And almost 60% live in First Nation communities. And among the, there's registered status that are under the registration under the Indian Act, and then there's also non-status Indians. But I also like to point out that it's important, like this just, you know, you have to know the diversity of First Nations. Like they're all the, you know, they have their Cree, Ojibwe, Oji Cree, Island Lake area, the Dene in the far north, and the Dakota. I put Lakota there because I think That one is from most of the our relations in the northern states, so Dakota. So, and then we, so just to recognize that, you know, a lot of times everything has been pan native. Well, really knowing who these, who we are is critical. Don't assume, you know, we're Cree or we're Ojibwe. We're all, we're not just First Nations. And that's like a legal term given by the government. And there's a lot of work being done by the Assembly of First Nations and the Assembly of Manitoba and of Canada, the national, on self-determination and self-government. The Métis people, which I'm, you know, a proud ancestry descendant of that. In Manitoba, there's about 120,000 and 50, it's kind of like 50-50 living in the urban center of Winnipeg and 50 living in communities throughout Manitoba. And the Métis are Manitoba Métis, Red River Métis. That's how they identify themselves. And the language is Michif, which is, you know, a combination of some French and some Cree. But you'll find a lot of Métis people will speak either Anishinaabe and Cree and that. And then the Inuit are also part of the Indigenous people, but a lot of them, when I was looking for information, that 1,000 visits to healthcare facilities in Winnipeg from the Inuit from Kivalliq region of Nunavut. And I might have to take off my I'm unstable there. I'm showing myself here. I become unstable. It becomes unstable. So you're going to see a lot of Inuit, 15,000 in our facilities, especially in Winnipeg, of the Inuit people. And they have their own language, and so some have to relocate to Manitoba because they can't get that care. So I think it's important, you know, to really differentiate among that. Okay, so for trauma-informed care, so it's a relatively new concept. Like there's some information, you know, when I was looking for how is it defined, and Clinic has done a lot of work on it, and they actually have a toolkit, which I have in the references. So it's a really good one. So it's an approach to deliver care that recognizes the impact of trauma and emphasizes physical, psychological, emotional safety for both us as practitioners and also the survivors of trauma. And it's a practice that seeks to create physical and emotional safety for survivors that help them to rebuild their, wait, I don't know what I wrote there because you got, wait, let me just, okay. To rebuild their sense of control and empowerment during interactions. And I think this is really powerful because often we just go in, you know, working in a walk-in or in primary care, or the work I've done in communities for over 20 years, not realizing this, and that, you know, the decisions they made, their health was influenced by the trauma they experienced. And I really like this next statement. Viewing trauma as an injury shifts the conversation from asking, what is wrong with you, to what has happened to you. I've seen this in several documents, and I thought, when I'm in my own practice and, you know, you hear that from other practitioners, like, what's wrong with them? Why are they doing this? And then when, you know, I like to see that part, what has happened to you? So now I try to frame it that way, especially my work in the North End. And of course, in the communities that I also work into. So it gives you a good sense as to what's been going on and what impacts them. And when they talk about traumas, it can be anything from physical, any of those, violence, sexual abuse, emotional abuse, childhood neglect. There's a lot of research on the ACE study and all those adverse environments that children grew up that are impacting them as they move into adolescent and adulthood. So there's a lot of research on that. And that's where most of the data came from when looking at the trauma research. And I guess for children and others, when they're from a sudden unexplained separation from a loved one, as we know, children in care, poverty, sorry, I went back there, poverty, racism, discrimination, and oppression. And I think Jessy, you know, explained that well in his discussion on those. And of course, violence in the community. Other traumas can be living with a family member with mental health or substance use disorders, can be traumatic. And there's a whole host of other ones, so I just kind of picked over those ones. But when working with Indigenous populations, we have to look at what is historical trauma. And there was a lot of work done by Maria Yellow Horse Braveheart. And so that's where a lot of this came from. What is historical trauma? And she defined it as a cumulative emotional and psychological wounding across generations, including the lifespan, which emanates from massive group trauma. So when looking at it, cultural genocide. So for Indigenous populations, there was destruction of governance and family systems, and we've witnessed that, or we're living with that through the Indian Act, residential schools. In the last, years, we've seen the whole TRCC. 60 Scoop is relatively new, but we're, becoming more aware of that. And currently today is the child welfare system and its impact on Indigenous families. Other cultural genocide is destroying of political and social institutions. So we know with the Indian Act that the traditional forms of government were banned, and the chief and council was created by the government. It wasn't a form of governance for our First Nations people. And of course, there's always that land, which a lot of First Nations and the Métis are still struggling with. And these lands were resource-rich areas. And that's where populations were forcibly transferred. So Indigenous people, First Nations, were moved off the lands and put into these land bases, which are reservations. And again, that genocide was with movement restrictions, and such as reservations or reserves, we call them in Canada. And with that, there was pass systems where people had to get a pass from the Indian agent before they can leave the community to go and do something outside. So it was really destructive for Indigenous people. And of course, we know about the languages that were banned, especially in the residential schools, and the children not being able to speak the language or they were punished. So we're trying to reclaim those languages now. And my parents spoke Michif, Anishinaabe, but they didn't want us to learn because they were afraid we would be discriminated against. So yeah, so that's a trauma, I find. And also our ceremonial practices were banned, like the potlatches in the West Coast, the traditional sun dances, etc. The Medeo in for the Ojibwe people had to go underground. But again, there's a lot of reclaiming of those practices. And of course, families have been disrupted to prevent transmission of cultural values and identity from generation to generation. And that's where we see that a huge impact with the residential school system, the 60s scoop, and now the child welfare system by removing our children. And currently in Manitoba, there's like 10,000 children in care, and 90% are Indigenous children. So, and they're put in non-Indigenous homes where they're losing their identity and so forth. And yeah. And one of the other ones with this historical trauma talks about biological genocide. This is huge again for our for Indigenous people, because it's destroying the group's reproductive capacity. And we've seen that with forced sterilization, and that has happened in the 60s and the 70s, and probably today we see that, but we don't know about those stories. And for me, it's impacted me because my mom shared with me is that she was, she gave birth to 7 children. And after her 7th child, she was she was sterilized, and I didn't realize that. So like, that's traumatic for me. And, you know, like learning this at this time, when I think about, you know, I may have had, you know, more brothers or sisters and more of a family. So, yeah, so I'm getting quite emotional over that. Okay. So you can see when you're seeing an Indigenous person that, you know, there's a lot of things to consider when you're looking after people. And if they come in with substance abuse, mental health, or just seeing them for regular routine care, that they may have been impacted by this. But one of the things I'll say is that, you know, working in a clinic like primary care, like you only have 30 minutes. And sometimes I'm just meeting them for the first time. And walk-in clinic, I usually have sometimes a little bit more time, and people want to share. They'll say, oh, I want to share my story with you. So I feel honored for that, to, you know, when they're telling me, you know, if they were suffering from that intergenerational trauma. If there were, and most were in foster care that I find that are having real trauma in their life, that are either homeless, have mental health, struggle with substance abuse, and so forth, living in poverty. When I get to know them, and I'm meeting them sometimes for the first time, or they access the service because we'll see that when we're so we should really understand the health effects of trauma, and recognizing that this negative coping behavior may be a response to trauma. And also, as a primary care, this medication adherence may be influenced by trauma. And some of the things I read was that, missed appointments, overuse of walk-in clinics because they can't get to their primary care because they're very, appointments, especially during COVID, are hard to come by. And a lot will use emergency visits rather than their primary care to access care, because at that time something pressing may be coming along and they're just on survival mode. So you'll find there may be lack of preventative care. So women may have not had PAPs done, went for their mammograms, blood work, etc. So I think before I used to get upset and say, why didn't you go to that, And so now I'm trying to be more understanding that they had, they may not feel comfortable, having that pap smear. The work by, I think it's Annette Fiske in BC, who did some work around cervical cancer, and her research, a lot of those risk factors were, blaming the women, as promiscuous, and that's why they had, cervical cancer, because of those risk factors. So we have to be careful with that, how we label women, and also diabetics. They may be living in poverty, education. A lot of our communities don't have access to diabetes education and so forth. So we need to remove that blame and see what else is going on. And as for medication, how it's influenced, some of those side effects. So some of the people may not be prepared to use it if it's going to make you drowsy. So they may quit on their antidepressants or anti-anxieties and prefer to use the benzos instead. So a lot of education around that as well, and understanding where they're coming from. So I read this, like you'll see in my references, I didn't make this up, that it came from some good sources. So I think one of the things that suggested that we need to recognize that many patients have a history of physical, sexual, or emotional abuse, as well as serious illnesses and negative experiences in the medical setting. And we need to learn to respond with empathy and understanding. And Jessy had mentioned that a lot, that, that trying to be kinder. So, yeah, and sometimes it's hard when, you're busy, you're understaffed, and it's hard to be, you want to just move them along type of thing, but yeah. And I think as institutions, we have to, it's important for those principles of trauma-informed care as well, making sure we're asking for permission, giving them control, and finding support. So saying, do you want to be tested? Like today, I'll say, do you want to have your pap smear today? I don't, say I'm going to do it. So I give them that option so they feel they have a bit of control. And also what's huge is that interprofessional collaboration. I like about primary care is that we have a lot of some resources in our area, but not as much as we should. And in the settings that I work, I like to be aware, and I think we should all be aware of what are the available resources, like in the North End. Mama Way provides some a lot of resources, all the homeless shelters, RAM clinic, and CRC if they're in crisis. A few times I'd have to send patients there that came in crisis, knowing about Cody, OAT if they need to, if you're dealing with somebody on opioids, and so you need to be aware of that, and also detox. And so kind of having all those, we have them available. And really, I think, like I say, it's, having a little bit flexibility just to listen to their stories. And I think when they feel respected, you can see the difference and how they want to. I, met one person and she was like on oat therapy, and she felt motivated, after seeing me. Not that but she wanted to increase her education and so forth. So, and it's good to see that. And this is where I found the references, and this one was by Margot Greenwood and Dr. Makosis from Alberta. So they did an excellent, it's probably like an hour long or maybe even 2 hours. They had so much information there. And then the other one I had participated in is with the Victoria Gynecology Update. And that one was a, how do you apply that trauma-informed care in the obstetrics and gynecology? So I learned some new information from there, so I was grateful for that. And then, of course, Clinic here has that trauma toolkit, and they also have some trainings that you would, but I think that they have some online, but I think there's a cost to it. And then I picked up a book that was referenced in Dr. Whitehill by Gerber. I think Dr. I don't have the first name here, but I was able to download it. But yeah, just kind of helping me, as I continue learning about trauma and how to provide that care. That's it.
Wonderful. Thank you so much, Rhonda. I think we have time for one or two quick questions if anybody has anything.
Oh, yeah, sorry. Did I talk too long?
No, all good. See in the chat, we do have one comment from Bryn that says the Eagle Urban Transition Center has a patient advocacy program. Thanks for that, Bryn.
Yeah, thank you. That's true.
Thank you again, Rhonda. Our final speaker for the night is Jennifer Cumpsty, who is the Acting Executive Director for Acute Inpatient Services at the Health Sciences Center here in Winnipeg. She is also the Deputy Incident Commander for HSC's COVID-19 Incident Management Leadership Team. She is currently working on her capstone for her Master of Health Sciences, where her area of interest is trauma-informed leadership. Please welcome Jennifer Cumpsty.
Thank you, everybody. I'm just going to share my screen. And can you see that? Perfect, thank you. So first of all, I want to thank the other speakers. This was a fabulous evening and I've learned so much from you. So my name is Jennifer Cumpsty and I am at HSC. And this evening, I just wanted to start off by a bit of a disclaimer. In saying I'm not an expert on trauma-informed leadership, but what I wanted to do is share with you some of the things that I have learned during the pandemic. I am a learner and I feel I'm continually growing as a leader, and I think there's a lot of value in us learning from each other and shared experiences. So I'm honored to be here and share my experiences and some of the things that we've been through at HSC, where I see trauma-informed leadership and the role I see for it in the future. So I think the first thing I want to say is that as nurses, we're all leaders, and we know that. And so there's opportunities for us to nurture not just only our patients, but our colleagues and those people that we're leading. So really, what is trauma-informed leadership? It's the style of leadership takes the aspects of trauma-informed care that we've been talking about and applies it to their leadership practice. So like I said, being aware of our teams and how do we support our teams and help our teams grow so that they can provide patient care in a healthy environment. And the idea of trauma-informed leadership, when you think about it, it really aligns with Greenleaf's servant leadership style, where we put the needs of others first to help them grow and to develop and to reach their full potential. So through the pandemic, there's a couple things that I think that trauma-informed leadership is quite where it's important and think where it's applicable. So first, we need to recognize that individuals and teams have been impacted by trauma during the pandemic. As leaders, we need to realize that our teams will continue to be impacted by that pandemic even after it is declared over. And that as leaders, we need to create a supportive work environment to support our teams. So healthcare workers are the same as the general public. So if you think about the fears and anxieties that we have all had over the past 2 years related to COVID, related to maybe financial hardship, people have lost jobs. We know that businesses have collapsed, the social isolation, of not being able to see family or children being homeschooled. All those things that the general population have experienced, healthcare workers have experienced as well. When you think about the additional stressors that healthcare workers have had, we've had stressors such as PPE. We had changing guidance as the science changed, so that was something we needed to keep on top of, as well as there were concerns in the beginning of the pandemic about access to PPE, and that caused a lot of stress and trauma for people. We had patients dying from COVID, and that was very scary, although we have had patients die, and we do have patients die every day. This was still an unknown, and it was something new for us. And I think one of the biggest things that we've heard is that fear of contracting COVID-19 yourself and giving it to your family members. And not only was it that fear, and we do know that that did happen. We know that healthcare workers did contract COVID-19 on the job, and they did take it home. And so I think that added to the level of trauma and stress that people have been experiencing over the last 2 years. So this prolonged exposure to trauma, we know, can impact people's psychological health of healthcare workers. And so when we think about that in the workplace, it can cause anxiety, disengagement, apathy, and it can cause agitation. And when we think about workplace psychological health, it's really our ability to work effectively, and it's related to the way that at work that we think, feel, and behave in the workplace. And we think about the fact that we're being trusted with vulnerable patients as well. We need a well workforce to make sure that we can care for patients. I think just to look back at the impacts of pandemic trauma on healthcare workers. So at the end of wave 1, there was actually a study done. It was a cross-sectional study at a large urban center in New York. And they looked at the impact of trauma and the COVID-19 stressors on the healthcare workers. And they looked at about 640 people, and they measured stress symptoms, anxiety, and depression. And it won't be surprising, I think, to any of us to learn that more than half of the participants screened positive for psychological impacts from the pandemic, acute stress, depressive symptoms, and anxiety. And there was another portion of that that actually met the clinical definition of PTSD as well. And that's pretty significant coming out of the pandemic. As you know, and many of you have lived, our experience in Manitoba in wave 1 wasn't the same experience as other jurisdictions. But in wave 2, we did experience that onslaught of COVID and the impacts here. And so that quickly became overwhelming to our healthcare system, our communities, and our healthcare workers. And there was an increased number of patients that were very, very sick, needing medical care. There was increased number of patients needing ICU beds. Our ICU beds grew dramatically and drastically. We had people dying. And it was very similar to what had been experienced elsewhere in the world. And even here in Canada, we had seen, even in wave 1 in Quebec, that there had been significant impacts there, which we hadn't experienced in Manitoba. So when wave 2 was ending in February of 2021, I was included in a group of nursing leaders, and we met with nurses and healthcare staff that had provided care at HSC during the second wave. And so in that meeting, the nurses shared their experiences with us. And they were very raw, very emotional, very personal, and I will say very impactful experiences that they shared about the impacts that working during COVID-19 and caring for patients had on them. They shared how sometimes they had cried before coming to work or after their shifts. They shared how some of them had never seen a patient die before they had been reassigned to the ICU. And they shared how when families couldn't be at the bedside, they were the ones that held the iPad and the impacts that had on them. They also shared that they felt leadership had not been visible. They felt there was a lack of communication, and they felt that they had not been included in planning and decision-making about providing care under such difficult circumstances. So after that meeting, as senior nursing leadership, we met to debrief and discuss about what had been shared with us. And we recognized that our teams had experienced significant trauma. And we needed to work with them to engage in a plan to help decrease the psychological stress that the staff are reporting to us, to create supports for them, to support their psychological health, and engage with them so that they could have some control in subsequent planning for the next waves that were coming of the pandemic. So as a result of these meetings, we had several initiatives that we put in place to support their psychological health and the impacts of traumas on our teams. The main thing that we did, which I think we had a lot of really good collaboration that came out of, is we started a working group with our ICU nurses, and we allowed staff to have input into the staffing model that they would use in the subsequent waves. So if you remember, we have a limited number of ICU nurses in Manitoba, and we did have to reassign or redeploy non-ICU nurses to the ICUs to help support that care. And so some of the things that those nurses that had been redeployed or reassigned and the ICU nurses shared with us is they hadn't felt prepared. So we went back and we took their feedback and we created more education, more orientation for them. And we actually built into day one some psychological help and supports so that they knew that they would be potentially in stressful situations, how they might react, what they might see in themselves, and the resources that were available. We instituted leadership huddles on the units, both to share information and to do check-ins, and these occurred daily. We also worked with our mental health team, who are absolutely fabulous. And in wave 2, they had done CISMs and debriefs for us, and we had made sure staff were aware of EAP, but we did more focused and individualized approaches for what the staff said that they needed. So we did daily wellness huddles and rounds, and these were initiated in the clinical units. And we didn't just focus on the ICUs and the emergency rooms and the COVID units. That spread out to every single unit in HSC. We had lots of outbreaks, and as you can imagine, that was stressful for staff. And we wanted to make sure we were doing check-ins. The other thing we became aware of is that our frontline managers were also experiencing quite a bit of stress. They were often the ones delivering these messages. So we started doing check-ins with them as well. And we put in some supports for them and from a leadership perspective to try to help them work through some of the challenges that they were having, the feelings that they were having, and some communication strategies to help them in their daily work. We also tapped into our spiritual health resources for staff. So traditionally, these are quite often be used for families and patients, but we had the spiritual health teams were actually involved with the staff as well. And they know the staff quite well, so they would sometimes see staff struggling, might be able to pull them aside, maybe even pull them off the unit and have a conversation with them. We developed quiet areas in the hospitals, which were called safe zones. And we utilized dimmed lights and relaxing environments. And these were away from busy clinical areas so staff could escape if they needed to for a few minutes and debrief. And we told people they could go there, they could nap if they wanted, they could listen to music, they could even go there and cry if that's what they needed to go and do. And we did have those areas available for staff 24/7. We also, with the assistance of our mental health teams, we put wellness sessions in place. And so those were some self-care things that people could do. We had virtual sessions for those, and they were related to things such as sleep techniques, exercise, mindfulness, meditation, things that people might help them just get through their day if they were trying to work through things at home even. And so with that, we also uploaded those to our YouTube channel. And we know that those were accessed quite a bit so that was a resource staff could access 24/7 when they weren't at work or if they just felt they needed to reach out. And the last thing that we did, which is probably honestly the most popular, was we introduced on-site therapy dogs for the staff. And so we had some therapy dogs in the past for patients. And as with the shutdowns that had happened and reduced visitation in places like PCH homes, the therapy dogs were available. And we actually started off with just a couple therapy dogs and limited sessions. And we got such positive feedback from the staff about the introduction of the dogs. We expanded the program, and they're there quite consistently now, pretty much every day, at least at some point of the day. And the staff could leave the unit and just step outside. And if we knew a unit was having a particularly challenging time, then the dog might even show up in the hallway outside the unit, and staff were able to go out and access the dog and pet them. And they reported decreased stress with that. So all these initiatives were really to try to incorporate a trauma approach. So we acknowledged that trauma had occurred. We allowed our healthcare workers to feel that they had some control or input in decisions that were being made that directly impacted them. We tried to improve the communication to alleviate their fear, and we tried to offer supports in the workplace to address their psychological health. As our team entered the third wave of the pandemic, although they reported being exhausted, when we did our check-ins in our working groups, which we still have to this day, they shared with us that the changes that we had made, they felt they had been engaged and supported, and it allowed them to go forward and adapt and continue to provide care. So that was very positive. And so I just think that, trauma-informed leaders I've included here, they include healthcare workers in decision-making to allow them to gain a sense of control. They consider physical, emotional, spiritual, social, and intellectual aspects of well-being. And I think that's something that we all need to continue to try to do as we go forward. I think the full impact of the pandemic on our psychological health of our healthcare workers obviously is not fully known because we're still living this 2 years later. But I think it's realistic for us to expect that there will be long-term impacts for some of our staff. We are going to need in the future as leaders to focus on the psychological needs of our healthcare workers and our teams And as leaders, I think we are going to have to incorporate a level of compassion and understanding into our leadership that potentially we haven't done before. And this is going to have to come a core component of our organizations, because we need healthy workforces so that they can care for patients. And I think just to leave for tonight, I would say that I think my last thought is that trauma-informed leadership will continue to be essential leadership style, and we will need to continue to provide that ongoing psychological support for their mental health in the future, even after the pandemic is over. And as nursing leaders, I really see this as a role. We are caregivers, and we are nurturers, and I think there's a role for us as for nursing to take on this and take this over. So thank you.
Okay, we'll open up the floor for any questions for Jennifer here.
Hi, Suzanne, it's Karen. There's nothing in the chat at the moment. I don't know if anybody has any questions or something to comment on. If not, I will have a question from the GNSA group.
Go ahead, Karen.
All right. Very good presentation. It certainly highlights healthcare and healthcare during the pandemic. You mentioned there was some supports that you guys put into place at the Health Sciences Center. I was just wondering, there's so many challenges in healthcare prior to the pandemic, and that the pandemic has sort of highlighted these challenges that we have. What did your group or you in person learn from the pandemic that you could apply to support staff moving forward? You had mentioned a few. I was just wondering what you would kind of move forward as the pandemic maybe hopefully starts to wane, and then make it a healthy workplace with staffing shortages and everything.
Yeah, thank you, Karen. I think that in terms of things that were identified to us, I think one, we listened to our staff and our teams to find out what they needed, because we couldn't make assumptions about what they needed. We had to listen to them. They needed control was a big part of it. They had felt a loss of control, which I think is a big part of trauma-informed care. And part of that was, for us, was to go back to them and say, what do you need? What can make this better? I think going forward, there's opportunities for that. I think for the nursing shortage, we know has been coming for quite a while. Controlling work, although we are in a 24/7 operation, there are opportunities where we can optimize things like scheduling, allow people to have a little bit more control of that. Maybe they will be able to create some work-life balance. And I think going forward, we're going to have to really put a value on supporting our healthcare workers. I think in the past, we've tried to fill shifts because we're urgent, but I think we're going to have to be a partnership going forward. And I see that as kind of our pathway forward.
Thank you. I agree. I think just a partnership, decision-making and compassion, you mentioned that in your presentation as well, compassion, leadership, just to understand everyone's positions.
I see there's one question in the chat here from Katie. Why do you think these ideas were not in play prior to the pandemic?
I think that's a very good question, Katie. You know, I think healthcare is in many ways, at times, impersonal. We are moving forward with lots of, almost on a mission. And so I think the pandemic maybe has caused us to stop in many ways in all of our lives and reflect on what's important. I think that we have recognized that our staff are very, very important, and our teams are very, very important, and their health is very important. I think this is a turning point, personally, for many leaders, recognizing that we have to support people, and we have to make sure that we're all well. I worry sometimes even about our leaders and our even our managers and our directors. We have all been functioning at such a high level over the last couple years that people are exhausted, and we need to heal. We need to mend so that we can go forward. And we can't have, in my mind, we can't have this be just restart everything the way it was. We have to have learned something out of this. And I think that value and the recognizing the humanity of not just our patients, but our staff as well, should be the lesson learned out of the pandemic.
Wonderful, thank you. And one more question, I think it'll be a last question for tonight from Wendy, who asks, in that partnership approach, which says I support, how do you see the collective agreement influencing what flexibilities may or may not be possible?
Thanks, Wendy. We actually have in the collective agreement self-scheduling. Not all areas use it. I see that as something that maybe we haven't explored. So when we talk about allowing nurses to have some control over their life, to do some work-life balance, that's actually one of the things that's built into the collective agreement. I have used that before in one of my roles in women's health, and that was great for some staff. So I think that allowed them to balance things like young children and daycare challenges, swimming lessons, things like that. So I think maybe we need to go back and we need to talk to people about that. It's very easy to stay in patterns of putting out set schedules every 6 weeks, and people are locked into them. But I think we have to be more creative going forward. I think there's also, yes, you're right, Andy, they did do that. I think there's also some opportunities to learn from other provinces, and we don't necessarily have it built into our collective agreement in the current state, but there are, I believe it's Ontario that has things like where nurses can bank away part of their EFT and then they can take a leave, whether it's for education or personal leave, and they've almost prepaid that. So I think that going forward, we'll need to look at some of those things. And I know that out of the last collective agreement, there's also been some look at how we can retain nurses in terms of retention. There's a provincial group working at that. And really, it's going back to the nurses and asking them what they need to create that balance and what can we do within the collective agreement. I think there is some things there that we can do. And we just have to be open to maybe not doing things the way we've always done them.
Wonderful. Thanks so much, Jennifer. So with this, we'll now like to bring closing remarks for the 12th Annual APN Conference. First off, thank you so much once again to all of our speakers tonight, Dr. Harder, Jessy, Rhonda, and Jennifer. We truly appreciate you all taking the time to be here tonight and sharing your knowledge with us. I've personally learned so much on how to bring a trauma-informed care lens into my practice moving forward as a graduate nursing student. Thank you as well to Leslie, Dr. Dick, and Natalia as well for joining us today. We would also like to give a huge thank you to the many different people who made this event possible tonight. First off, thank you to our APN committee, including Jess, Karen, Christy, Abby, Karenvier, Dami, Vaughn, and Vanessa. And also thank you to the GNSA, including the Volunteer and Communications Committee, and a huge thank you to the College of Nursing as well.
And a few final reminders before you guys leave for tonight. Door prize winners will be notified by email address as well as social media on the GNSA pages. I mean, there's still time to also make a donation to One Just City. And lastly, we would like your feedback on the APN conference for future planning. So I believe Ashley will just put a link into the chat there for anyone who has some time to fill that out. And once again, thank you everyone, and I hope everybody has a good night.
Thank you.